Good afternoon. So my name is Dr. Samuel. I am an OBGYN resident doctor here at Lincoln Hospital in the Bronx. So today I'm going to be presenting a case that I encountered not that long ago. It's the title of my presentation is a perinatal outcome complicated by long chain fatty acid disorder. And these are some of my colleagues that I worked with. So briefly, so fatty acids, they are the largest energy reserves in humans. They constitute a vital role in supplying energy during instances of fasting and stress through a beta oxidation pathway in the mitochondria. So this pathway is actually very important in neonates who have paucity of glycogen reserve and a very high metabolic rate. Occurrence of a precipitous metabolic decompensation could occur if there's any disruption in this pathway. Now, long-chain fatty acid oxidation disorders, there are a set of very rare, potentially fatal autosomal genetic diseases, and they can impact both the perinatal and infantile period. These disorders could increase the risk of a number of very serious perinatal outcomes. This includes preterm labor, delivery, intrauterine growth restriction, preeclampsia spectrum, and neonatal health, and eventually even possible demise. So this case report that I'm going to be discussing talks about a case where a neonate was diagnosed with long-chain fatty acid oxidation disorder. So the case involves a 22-year-old primiparous Hispanic woman who was a late registrant at a 29-week gestation. So she had no prenatal care, she had a language barrier, and that she did have an episode of preterm contractions 1 week prior. On ultrasound, they showed that megacisterna magna of the fetus. Genetic evaluation showed low risk NIPT, which is basically just a genetic disease, just looks at cell-free DNA. The patient declined genetic amniocentesis. This patient came in for labor at 34 weeks and 6 days. She was diagnosed with preeclampsia with severe features at that time. She was given empiric antibiotics for unknown GBS status. So this patient ended up delivering 5 hours later. It was a female infant. Baby was weighing about 2,000 grams. APGARs were good, 9.9. And GBS culture came back later being positive. Now, after the mom delivered, the baby was fine initially with the APGARs of 9.9, but 1 hour later, we noticed that the baby had hypothermia of 92.1 degrees, and baby was placed under a warmer and noted improvement. At 32 hours at life, the neonate was again hypothermic. The baby was weak and showed nasal flaring. And because of this, the baby was admitted to the NICU for sepsis evaluation and monitoring. So a number of laboratory diagnostics were ordered, including CBC, CMP, CRP, blood cultures, and a lumbar puncture was performed. Empiric antibiotics were given, including ampicillin and gentamicin, because of the high suspicion of sepsis. They did a sonogram of the baby's brain, and it was negative for any malformation. At 50 hours of life, this neonate did not improve. She started showing oxygen desaturation, increased respiratory rate, very slow heart rate, and was intubated. Despite all resuscitative measures, the neonate eventually expired. So some of the findings that came back later was that this neonate had elevated liver transaminase. The newborn screening, which is done on all neonates, came back showing that this baby had a long-chain fatty acid oxidation protein deficiency. The CSF showed pink color, low glucose, elevated protein. And then an autopsy was done, and it showed that the immediate cause of death was sepsis with involvement of the brain and the lungs. However, the long-chain fatty acid oxidative disorder or disease was contributed to the poor outcome in this neonate. So just kind of bring everything together, mitochondrial fatty acid oxidative disorders, they are errors in metabolism, and they are inherited in an autosomal recessive pattern. So there are many different types. Some are associated with pregnancy complications in the heterozygous mother, and they could be also responsible for fetal growth restriction, preeclampsia, fatty liver pregnancy, preterm delivery, and they're most often noted in mother carrying a fetus that has this this type of disorder of long chain fatty acid disease. The newborns, when they're born, they show several abnormalities. These include metabolic acidosis, liver dysfunction, heart dysfunction, neurological dysfunction, and also hypoketotic hypoglycemia. To diagnose this, you have to look at the enzyme activity, and the parent has to be counseled that there is a risk that they might have a future pregnancy that it might have the same outcome, because this is an autosomal recessive disorder. And so this case, basically, just in conclusion, this case highlights the importance of high suspicion of this disorder and the importance of multidisciplinary approach for the benefit of both the patient and the parents. So that's my presentation. Is there any questions?
Yes, so if the metabolic disorder had been recognized, what interventions could potentially have been instituted that might have potentially altered the clinical outcome?
So it's actually a lethal disorder. So there really wouldn't have been that much that could have been done for the neonate. Neonates that does survive, they still have a very, very low, very poor outcome going forward. So there wouldn't have been as much that would have been done. I think one thing that could have changed was that we would have admitted the baby into the NICU earlier. Instead of leaving baby with mom, we would have noticed that the baby was decompensating. And then we could have possibly gave the baby like glucose or something to make sure the baby doesn't become hypoglycemic. So I think that would have been the one thing that would have changed. Baby would have been admitted to NICU earlier.
All right, sounds good. Thank you very much.
All right, thank you for your time.